Welcome to Caring for Patients with Nasal Polyps in 2023, When to Consider a Biologic or Surgery, presented by the Global Education Group in collaboration with the Asthma and Allergy Foundation of America and broadcast simultaneously in Immunology Live and Res Insights Live. This is the first module in this four-part series and is titled Key Symptoms of Nasal Polyps and Their Consequences on Quality of Life. My name is Dr. Stella Lee, and I'm the director of the Brigham Sinus Center at Brigham and Women's Hospital. Today's session is interactive, allowing us to take your questions in real time throughout the presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce Dr. Katie Buchheit, Associate Physician at Brigham and Women's Hospital and Assistant Professor at Harvard Medical School. Dr. Buchheit will be joining me for a Q&A at the end of the session. Thank you, Katie, for joining me today. Let's get started. These are our disclosures. These are our learning objectives for the series. We will summarize the burden of disease and treatment for patients with nasal polyps with the focus on outcomes that matter most to patients, such as the ability to smell, sleep, and be productive. Describe the type 2 inflammatory relationships between nasal polyps and common comorbidities such as asthma and aspirin sensitivity, AERD, or NSAID hypersensitivity, or NERD. Explain how enhanced knowledge of nasal polyp endotypes and type 2 inflammatory pathways can guide treatment decisions. And finally, review recent recommendations for the management of nasal polyps with surgery and/or monoclonal antibody therapy, especially as they apply to the management of uncontrolled severe nasal polyps. So our first module, we'll focus on the key symptoms of nasal polyps and their impact. This is a patient of mine who has a very severe nasal polyps, and you can see that there's significant obstruction of the nasal cavities and inflammation, as well as drainage. When we think about nasal polyps and how we evaluate the severity of nasal polyps, when they are this obstructive, we often look at scores such as nasal polyp scores. We look at other validated measures of inflammation and mucus, et cetera, such as the Lund-Mackay score or Lund-Kennedy score. But this patient has severe nasal polyps, and these are the types of patients that we struggle with the most. And hopefully, at the end of this module, we can have a better understanding of how to better diagnose and evaluate these patients. So let's talk about that. Chronic rhinosinusitis is inflammation of the nose and paranasal sinuses for at least 12 weeks. And it's based on two or more symptoms, such as nasal blockage and obstruction or nasal discharge. But patients can often have facial pain or pressure, and smell loss is certainly an important symptom that patients present with. It's also important to realize that not only the symptoms are important, but objective findings. So you need to have endoscopic findings of nasal polyps or drainage that can be mucopurulent at times, or edema when you look with an endoscope. Alternatively, you can also use a CT scan that can show mucosal changes, obstruction within the osteometal complex, and or obstruction completely of the sinuses. We have several consensus statements on how to diagnose chronic rhinosinusitis. This is one of them. This is the International Consensus in Allergy and Rhinology. And you can see here adult patients with sinonasal symptoms. If you look at the duration, as well as whether patients have endoscopic evidence of polyps, then you can diagnose a patient as either having polyps or no polyps. But this is a very basic categorization, phenotypic description that we're moving away from, and we're going more towards endotypic descriptions or understanding actually of the underlying pathomechanisms of the inflammation. This is another schematic table that shows us some of the symptoms that we talked about, such as the nasal discharge, the obstruction, the loss of smell, and facial pressure, pain, and the importance of having an objective finding, such as polyps, inflammation, nasal endoscopy, or CT scan or inflammation or drainage coming from the sinuses. Patients are often currently just divided into those two categories of with or without polyps. But as I mentioned, we are becoming hopefully more sophisticated in understanding the mixed types of inflammation that occur in these patients. Let's talk about assessment of symptoms, because this is a quality of life condition. And first of all, you can see here a sense of smell. Patients can have complete loss of smell or anosmia, or different levels of smell loss: hyposmia, microsmia, and normosmia means normal sense of smell. So there are different ways we can measure this. There's a score that we can use, as well as testing such as the University of Pennsylvania Smell Identification Test, which I'll talk about in a little bit. There's also scores to measure congestion, which is the NCS, and there's also a way to measure nasal polyp score, similar to what I mentioned in that patient who had really severe polyps on the nasal endoscopy video. And we do score patients from 0 to 4 on each side of the nasal cavity, so 0 being no polyps and 4 being complete blockage of the nasal cavity. So you can have a maximum score of 8 if you have complete blockage on both sides. SNOT 22, or the sinonasal outcome test, has 22 questions that look at patient-reported measures that are important for nasal symptoms, emotional symptoms, quality of life, ear symptoms, as well as sleep. So there are multiple subdomains within SNOT 22 as well, but there is a minimal clinically important difference of 8.9, which we often use to determine if it really is a significant change. VAS is another way to look at symptoms, and a reduction of greater or equal to 2 centimeters may be considered significant for that patient. This is a new concept of control, and unlike the asthma world, where there's so much research and understanding and following of patients who have of control of their lower airway inflammation, control of upper airway inflammation is now gaining some foothold. This is one of the tables, as you can see, looking at the concept of control. So on the top, you can see controlled, partly controlled, or uncontrolled, and the different symptoms, as well as objective findings and need for rescue treatment on the left-hand side. This is still being developed, and there was a recent publication that showed that when you actually not only include these concepts of control, but also incorporate patient assessment of control, it even makes the assessment better overall. And these are the terms I mentioned: uncontrolled as well as severe. We're now just beginning to incorporate these terms into our vocabulary. And as you can see on the left-hand side, the concept of uncontrolled is defined there: persistent or recurring symptoms despite use of intranasal corticosteroids. If the patient had received at least one course of systemic corticosteroids in the preceding 2 years, or prior sinus surgery, and there are other different details you can see below. On the right-hand side, the concept of disease severity. We are using nasal polyp score at times, but again, this is not completely accepted, and it's still not a way that is universally utilized. But it is one way of assessing polyp burden. And so you can see here that patients who have severe disease, you can say that patients might be severe if they have bilateral polyps that are with a high polyp burden, and they also have symptoms, as you can see below, that indicate that they might have a greater symptom burden in conjunction with the objective burden. Going to epidemiology of CRSwNP, we know that the prevalence in the US is about 2 to 16%, but that's a pretty wide range. We do need better studies to kind of understand what the actual prevalence is. The majority of patients do not have polyps. And as you can see, about a quarter to 30% of patients have polyps. So on the diagram on the right, you can see there's multiple different categories of polyp disease, and there's overlapping diseases and syndromes that interface between patients who have polyps and patients who do not have polyps. This is an adult onset disease. So patients often are in their 30s. The age of diagnosis for patients who have AERD is a bit younger, but it is about, the same range. It occurs in patients who are adults, not children. Recurrence following sinus surgery, we've studied this. We know that it can often be difficult to control the inflammation. The recurrence rates can be quite high. There have been reported rates of 40% in CRSwNP, but patients who have comorbid conditions, and Dr. Buchheit will talk about this in another module, patients who have asthma or AERD, it can be quite high, as you can see there. Important phenotypes include not only the patients who have the most severe polyp disease, which is the aspirin sensitivity, but also patients who have allergic fungal rhinosinusitis, which we don't really see much here in Boston, but in the South and other parts of the world where the climate is different and more humid, we do see patients who have really severe allergic fungal rhinosinusitis. The burden of CRSwNP is quite significant. Patients have sleep disturbance. They have altered sense of smell and or taste. Taste is a tricky thing. We often take for granted that when we eat food, that the way that we experience flavor is actually very intricately related to our sense of smell. So a lot of these patients have altered sense of smell and or taste. And unfortunately, because of that, and if you can't smell gas leak or can't smell spoiled food or fire, they have a much higher risk of being impacted by a hazardous event. There are significantly higher rates of depression and or anxiety, and we're seeing this even with our patients who have COVID-related olfactory dysfunction. And we are beginning to understand how impactful the loss of smell can be to our quality of life. Impact on overall health-related quality of life is also important to look at when you compare it to CRSwNP, that the patients who have polyps and chronic sinus disease often have significant decrements in quality of life, similar to patients who have COPD, who have asthma, who have diabetes. There's a significant reduction in productivity, and it's quite a costly condition. These are some examples, as I mentioned, about the ways we assess CRS, such as the SNOT-22, which you can see on the left-hand side, which is a patient-reported outcome measure of 22 questions. And then another way that we assess smell, which is a scratch and sniff test. It's an identification test, but there are other methods of smell testing, such as sniff and sticks, and threshold testing that can hopefully help us understand the severity and the degree and the characteristics of the smell dysfunction overall. This is a summary of all the patient-reported outcome measures. The ones that we most commonly use and we see in a lot of the clinical trials that have been done more recently include the SNOT-22, as I mentioned. The other tests, interestingly, such as even the SCT, the sinus control test, we are trying to better define the control of disease, as I mentioned, but we are still developing tools for that. And in widespread practice, these tools are not commonly used for assessment of disease control. But SNOT-22 is one of the most common tools that we use just to assess patient-reported quality of life. You can see here on this study when they looked at patients who have CRSwNP, and when you look at how important that particular symptom is to impacting their quality of life, that decreased sense of smell and taste is really high up there. It's almost as high. Well, I would say perhaps they're equal, and some studies suggest that nasal blockage is more important, but both blockage of not being able to smell or breathe through your nose and or smell through smell are both really important symptoms that impact patients. And you can also see all of the other symptoms that are quite impactful to patients' quality of life. Polyp recurrence is common. You can see on this schematic that in patients at 18 months, the polyp recurrence can be as high as about 40%. And patients also have edema associated with the polyps as well. And polyps and edema are likely synonymous, but the more important question is how impactful is polyp recurrence to patients' quality of life? So it is important not only to assess that polyps are coming back, but also how are they impacting patients' smell? How is it impacting patients' ability to breathe through their nose? And we know that that prior sinus surgery and worse preoperative severity can be risk factors for recurrence. So this can be really helpful for counseling patients when they're deciding on treatment options. So we do need more research into better surgical and medical treatments to really prognosticate which patients might have higher recurrence, and this we will discuss in one of the other modules. So in summary, chronic rhinosinusitis currently presents as either patients who have polyps or who do not have polyps, but we are becoming more sophisticated in categorizing patients with type of inflammation, type 1, 2, 3, mixed or untypable. So that is moving forward. We see patients with polyps in about a third of all patients who have CRS. And patients with polyps have severe and or uncontrolled quality of life. There are these numerous tools that we can use to assess patients, and it's very important to do this over time. Smell loss is really an important symptom to patients, and there are ways that we can measure that as well. And unfortunately, even with the best surgical treatments, polyps do recur quite often, and we do need to have more research on which patients might have more rapid recurrence and how to better counsel patients. So in conclusion, there are new and also emerging options that hopefully can help us address the above for medical management as well as surgical management, and hopefully improve our patient outcomes. So now we'll move to our Q&A. And I see some questions coming through. And I'd like to invite Dr. Buchheit back to our session.
Great, thank you.
One of the questions is about how do we assess for type 2 inflammatory disease? So I was curious if, Katie, if you have any tools that you really use to assess for this kind of inflammation in patients with polyps and patients without polyps?
Yeah, we have some tools, although they're certainly not perfect. As we'll talk about in a later module, most of the patients with nasal polyps that we see in the United States do have at least some aspect of type 2 inflammation, although many patients we think do have mixed inflammatory endotypes as well. But things that, certainly I do often when I meet patients are looking for sort of known markers of type 2 inflammation. And I'll often check peripheral blood eosinophil counts in my patients, or their serum IgE, just looking at their total serum IgE levels for elevations in either eosinophils or IgE. One thing I think that you do and we look at together certainly is, when patient either has a nasal polyp biopsy or polyp tissue removed during sinus surgery, we'll obviously look at the pathology and have the pathologist comment on, the presence and quantity of eosinophils in the tissue, which can be somewhat helpful. We do not have really helpful biomarkers to identify patients with non-T2 inflammation. So I think, that is certainly an area that we need to do a lot more study and really understand better.
Great, thank you. Another question is about loss of smell with CRSwNP. Is it reversible after surgery or other treatment? Loss of smell is tricky. it is mediated by the olfactory neurons and the olfactory bulb, as well as how we conceptualize smell essentially. So loss of smell can be reversible if patients, there's some studies that suggest that if patients, for example, respond to a course of oral steroids and their smell comes back with, oral corticosteroid treatment, which we don't recommend that we do. We want to limit the number of oral corticosteroid treatments we provide because of the side effects, but that might be an indicator that smell might come back. The way that I counsel my patients is that it's hard to predict, and the reason to do surgery, we try not to predicate it that this is the reason why we're doing surgery. And the reason for surgery is to allow for better access for topical therapy, to remove the inflammatory burden, to allow for patients to breathe, and potentially if smell does come back, hey, we'll take credit for it. But if it doesn't, then we'll have to think of other ways to address that. It looks like there's another question coming through about how we can better understand disease severity and control of symptoms using current tools. I'd love to hear from Katie about, in the asthma world, there's so much more advancements in how we do that for patients. What are your thoughts on that question?
Yeah, no, I think that we certainly have some tools, and I honestly, with treatment for patients with chronic rhinosinusitis with nasal polyps, what matters most certainly is how the patient feels, right? Not exactly what we're seeing endoscopically or on their CT scan. And, as you went through beautifully, it's a lot of different aspects: their sense of smell, how they're sleeping, congestion, and then, how it impacts their overall quality of life in many different ways. So, I do find in my clinic, I do use SNOT 22. Certainly that is not always realistic for everyone to do, but following that can be helpful. I think that simple visual analog scales can be helpful, or just asking patients honestly, like, how much is this impacting your quality of life, and going through the sort of important points that we know that nasal polyposis can impact. But there certainly, I think, is a lot more that we could do in terms of having sort of validated, widely used, simple measures that are a little bit more standardized.
Thank you. Thank you, Dr. Buchheit. And thanks to our audience for the great questions. I would also like to thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com and resinsightslive.com to view today's session, along with other sessions on demand. Stay tuned for the next session titled CRSwNP and its comorbidities, an even higher burden on patients. My name is Dr. Stella Lee, and thank you so much for joining us.